Dr. Kumarave is the alumni UG and PG from Madurai Medical College, and he did his Defend the Endocrinology in AIMS Kochi, and is the director and consultant in Alpha Hospital Research Center Madurai, and is the president of Endocrine Society of Tamil Nadu, post-developer in Fellowship of Clinical Endocrinology organized by IMA. He has organized so many national conferences and he had published so many articles in national and international journals, and he had contributed in revised IAP growth chapter. Welcome, Kumarave.
Thank you, Chairperson, and respected co-speakers, delegates, and my dear friends. The topic which I am going to discuss today is regarding gestation diagnosis, challenges and controversies. So probably we have always thought that this gestation is a challenge. How many times you speak, there's so much controversy. Why is it so? I think there are two lives involved at the same time. It is the fetus and it is the mother. And another bigger complication which happens is there are too many stakeholders. You have a gynecologist, you have an endocrinologist, you have a dietitian, you have a physician, and of course, party with him, there's a bigger stakeholder, and Google is another stakeholder. So whenever you have too many stakeholders and too many vulnerable groups involved, controversies and challenges tend to happen. So basically what I have tried to do today is I will give you a basic understanding, and I will try to touch upon certain controversies and challenges, and I will try to give you a clarity as much as possible. So this would be the overview of my talk. I would try to start with defining gestation diabetes, because basically when you are dealing with the disease, you should know what exactly is it. Then we will discuss about screening, whom to screen, and when do you screen, and how do you screen, and treatment. Why exactly you should treat a patient with gestation diabetes, and if you have decided to treat, how do you treat, and how exactly you are going to monitor the patient. And just for the understanding, I will just give you 3 or 4 case scenarios, so which is easy for you to understand what exactly we are trying to say. So as far as the definition is concerned, GDM or gestation diabetes is a carbohydrate intolerance of any degree which begins or is first time detected during pregnancy. So, which is diagnosed first, whether it's a pregnancy or diabetes. If diabetes is diagnosed first, it becomes pre-diabetes. If pregnancy is diagnosed first, it becomes gestation diabetes, irrespective of not whether you use insulin or patients on diet control, irrespective of your perinatal outcomes, irrespective of your future diabetes risk. It could also involve occult type 2 diabetes, which is not diagnosed pre-gestation. So any diagnosis which happens first time during pregnancy becomes gestation diabetes. So definition wise, I think there's not much of confusion. It is very, very clear. Second is, whom do you want to screen and when do you want to screen? So you have various criteria which suggest you have a high risk patients with GDM, you have a low risk patient with GDM, you have average risk patient with GDM, and they have certain risks. How do you say? Suppose you have a patient with marked obesity, personal history of GDM, patients with glycosuria, some families have diabetes becomes high risk. So you should screen them as early as possible. And usually they are retested between 24 and 28 if it is negative. And low risk patients are those with age less than 25 years, weight is normal, ethnic group with low prevalence of GDM, and no family history of diabetes. But what happens is, in our busy day-to-day practice, it's very difficult for us to get all these history and to see who has to be screened, who need not be screened. So I would say Indian settings, ethnically we have a high risk for type 2 diabetes and we are practicing in India. Obesity and PCOS prevalence is increasing, and we have previous speakers who have highlighted about PCOS, and we have various talks on obesity also. And it is not only the fat or weight which is increasing, there's a continuum of metabolic syndrome which adds to dyslipidemia, which in turn has various other risk factors. So universal screening is probably required in our setting. So it's very clear, all pregnant female has to be screened. So there's no confusion, you don't go for high risk, average risk. We are high risk, all our women has to be screened. The next challenge happens, how do you screen? Or how do you diagnose? So I tell you, the confusion arises because you have too many criteria. So much of criteria, and every year the criteria keeps on changing. And the beauty is that they just change 2 or 3 numbers. Many times I tend to forget the number also. Suddenly they say your target is 95, suddenly they say target is 92. I really don't wonder what this 3 milligram is going to make in our daily clinical practice. I would say this 3 milligram will have a major impact when you statistically analyze a patient. When you try to look at maternal outcome or fetal outcome, this 3 milligram will totally change your statistics. But when I'm seeing my patient, this 92 or 98 does not make a big difference for me. And you have so many criteria. What I would request the practitioners is that you follow any one criteria which you are very, very clear. Numbers will not confuse you at all. So initially, I think there are 2-3 criteria which is commonly followed. One, you do a glucose challenge test. I'm sure most of the gynecologists would be doing. And if your glucose challenge test is more than 140, some people use a cutoff of 130. Forget the numbers. You use 130, you are comfortable, you follow 130. If you are following 140, you follow 140. This 10 milligram is not going to make a difference in diagnosis. And once when a glucose challenge is positive, you do a oral glucose tolerance test, which is a 75 gram glucose. You do a fasting glucose, you go 1 hour and 2 hours. So basically, this is called two-step approach. You do a GCT and then you do a oral glucose tolerance test. And people thought this is very confusing to do a two-step approach and it will be difficult for the patient. So I think this Asia group, DIPSI, they came with a criteria. They said you do a single, they combined this GCT and they combined this OGTT. And they said instead of 50 gram glucose in GCT, you do 75 gram glucose. And instead of 1 hour cutoff of 140, you fix a 2 hour cutoff of 140. That's it. It's just a playing with the number game or whatever it is. And I was a part of this gestational diabetes guideline, which was initially formed by DIPSI. So basically, again, the request here is you follow whichever criteria you want. You either follow with the GCT followed by OGTT, which is what I routinely follow. If you are comfortable with DIPSI criteria, you're comfortable with DIPSI criteria. Follow up a criteria which you are very, very clear. And always see whether your criteria have changed, your guidelines have changed, your numbers have changed. So that is something which is very important when you are sticking to something which you are familiar with. So practical approach in our setting is that prenatally, if you happen to see a mother newly married or planning to marry, especially since the obesity is increasing, always screen women with risk factors. Prenatal 2 hours 75 gram OGTT is mandatory. You do a patient PCOS coming to you with infertility, not at conceive. Prenatal, definitely you should do a GPT. If suppose you are seeing a first time you are seeing a patient in pregnancy, if it's a first trimester, universal screening is definitely required. Two-step approach or one step, whichever you are convenient with, but I would prefer to do a two-step approach. So the cumbersome OGTT could be avoided for many of our patients. And for gynecologists, it's very easy. You may not send the patient back to come in fasting, and especially in first trimester pregnancy, when hyperemesis, everything is a major challenge, to bring the patient in fasting, it becomes a difficult. Second trimester, 2 steps may not be an issue. First trimester is always a challenge. Another thing which I would suggest whenever you are diagnosing GDM in first trimester, you do a hemoglobin A1C. The reason is that HbA1c reflects a 3 months average blood sugar. If your hemoglobin A1C is more than 6.5, it could be a prenatally undiagnosed diabetes which is diagnosed during pregnancy. The reason why I say this is required is that whenever you say GDM in a patient, first thing they would ask is koladhikku varuma. Whether koladha parmane sariya poguma. So these are the two things. They are least bothered whether you are going to treat it or not. They are bothered only with these two questions. So koladhikku varuma varada andre it depends on how strict the blood sugar is you are getting control, how good you are treating. Koladha bandhappa varuma varada, this HbA1c will give you a clue. If this first trimester HbA1c is 5.2 or 5.4, I could say definitely it may not continue after delivery, it would recover. But if the first trimester HbA1c is 8.2, I would say this is definitely going to continue. And if that is negative at 24 to 28 weeks, again universal screening, two-step approach. If all these are negative, still I would say after 32 weeks, you do a selective screening, which may not be for every individual. Suddenly you say disproportionately there's a fetal macrosomia, oligohydramnios, polyhydramnios, and increasing renal glycosuria. I'm sure renal glycosuria could commonly happen in pregnancy. Whether there's disproportionately increasing renal glycosuria, you can go for screening. So now we have seen the definition, we have seen who has to be screened, we have seen when they have to be screened, we have seen how they are screened. Next is treatment. Diagnosis alone is not important. Why to treat? The second thing, most of patients, 200 இருந்தா என்ன சார், எனக்குலாம் 500 தான் இருக்கு, நீ கண்டிப்பா வைத்தியம் பார்க்கணும். We would say நீங்க மாசமா இல்லமா, உங்க குழந்தை மாசமா இருக்கு, கண்டிப்பா வைத்தியம் பார்த்து தான் ஆகணும். So that is one part we can casually tell to the patient. But now after this Google, you should give them some evidence also. So you tell that's a potential fetal complication which starts from macrosomia, birth trauma, prematurity syndromes, neonatal hypoglycemia, hypocalcemia. There are so much to happen in the fetus. Potential maternal complications, which I'm sure is a major concern with the gynecologist. There's increased preeclampsia, hypertension, urinary tract infection. There's increased incidence of cesarean section, and the probably increased incidence of future diabetes. So definitely it has to be treated. And the next question arises is your HbA1c and your maternal fetal outcome. So when you look at the HbA1c, and the data is very clearly shown, when your HbA1c is less than 6 with GDM, your fetal congenital malformation is just 9.3%. But when your hemoglobin A1c in pregnancy is greater than 9.5, there is a 37.5% of fetal congenital malformation. So this data is very clear. Now, the challenge here is that you diagnose a patient with first trimester, 8 weeks, blood sugar is 180, and HbA1c is 10. Now the question arises, the gynecologist saying, sugar doctor பார்த்துக்கோங்க அவர் என்ன சொல்றாரோ பண்ணிக்கலாம். As a sugar diabetic specialist, we can only control the sugar, but we cannot say to continue pregnancy or not. So when you try to look at MTP loss or other things, MTP can be done if it endangers the mother's life or it endangers the fetus life. It could be for various reasons. So this, you have a probability of things are happening. So in such scenario, it's a very, very big challenge to really take a decision. So we say if it depends on it's a elderly preemie, precious pregnancy, all these things probably we try to discuss the pros and cons, and the challenge here is to take a decision with discussion with the patient. When you try to ask me as the thumb whether you want to continue, I would say you continue, because there is nothing to say it has to be aborted or no MTPs required. But when you try to discuss, try to take other histories, socially sometimes you may be forced to stop it, but evidence clearly suggests it need not be done a MTP when you have a high HbA1c, but the probability of having malformation has to be explained. So when things were going smooth, when things were clear, now then I would not say it's a controversy. Whenever new data becomes, it becomes a controversy, and then when you become a clarity, everything becomes sortable. Recently, we have a data which is published where treatment of gestational diabetes in early in pregnancy. Initially, we were diagnosing in second trimester, and only when it is repeatedly abnormal we were treating. This was a very interesting data which was published by Mohan's group, where they tried to look at treating GDM patients even before 20 weeks of gestation, and they showed it had a favorable outcome in terms of your neonatal outcomes were better, but there was no immediate treatment. I'm sure, because the reason I'm telling this is most of your patient will come to you with these data. You should be able to convince them or discuss these data with them. But as of now, the gold standard is that you screen them in the first trimester and treat them based on the criteria what we have. So next, when you have decided to treat, you should know what is the target. Again, here controversy here is your diagnostic targets are different from your treatment targets. Diagnostic, you say your 1 hour should be say 180, but in treatment, you say your 1 hour should be less than 140. Because diagnostic, you have glucose challenge and tested. So your fasting should be less than 90. Your 1 hour should be less than 140 and 2 hours should be 120. Probably some guidelines would say 130. It's just a number game, but it could vary between 10% plus or minus, but this is what your guidelines suggest. And if you are going with hemoglobin A1c, it should be less than 66.5. But again, hemoglobin A1c in pregnancy could be falsely high or falsely low. And hemoglobin A1c takes 3 months for you to show an absolute reduction or absolute change. And pregnancy itself is just 9 months. We cannot afford to wait for hemoglobin A1c. In such scenario, we can use fructosamine, which reflects 2 weeks average blood sugar. So this is the cutoff is between 205 to 285. So now mostly we use fructosamine in monitoring your GDM patients in pregnancy. The second challenge is a medical nutrition therapy. Once when you have decided to treat, all treatment of diabetes or any lifestyle disease starts with the MNT, starts with exercise, then only comes the medication. Straight away, don't jump in and put them on medication. So you have various ways to calculate the calories, but basically the challenge here is in pregnancy, instituting a medical nutrition is very difficult because it's not the patient's decision alone. It's a whole decision of the in-laws, the whole decision of the mothers and the husband. There are so many tests. I would say, though the guidelines are very clear with medical nutrition therapy, it's a very challenge to discuss with the parents and decide. The one thumb rule is that whenever your patient's ideal body weight, you give 30 kilocalories per ideal body weight of your calories, and based on carbohydrate should be 30%, fat is 30%, protein should be another 20%, and adjust the diet based on your weight gain and ketones. The next controversy is exercise. Pregnancy or exercise or there would be your high risk pregnancy, you are supposed to take this. They have various reasons why they should not do exercise. And sometimes they ask us whether you want to do exercise, and they come and tell the gynecologist, sugar doctor exercise panna vendam soltaru. But I think it is very clear, we make it a point, exercise we always want you to do, but always discuss with the obstetrician, because she can have some cervical incontinence, whatever it is. So you discuss with the obstetrician. But my recommendation would be to do exercise 3 times a week, at least 45 minutes a session. And it is always advisable to doing exercise should continue the same. Please just they are doing it. And if you are not able to do a severe exercise, at least do a gentle upper body exercise has to be done. Next is a drug therapy. So drug therapy, insulin therapy is the cornerstone of management of diabetes in pregnancy if diet alone is inadequate. So initially human insulin analogs were used, and SMBG should guide the doses and timing of insulin regimen. And OHA were considered absolute contraindication recently till then. But now I think we have so much data to suggest metformin has been used in pregnancy, and even certain textbooks say Dianyl, that is the glibenclamide, has been used. But I would suggest as a gynecologist, stick on with insulin, because even if you have a medical legal case, if a OHA is started by a specialist, they might escape. But if it's started by a gynecologist, it might be a problem. But if nothing is possible, giving OHA may not be an issue. But when you try to take data or guidelines, it is still insulin which holds true. Insulin requirement in first trimester is weight into 0.7, second is 0.8, and third trimester weight into 0.9. If the patient is a pre-gestational type 1, your insulin requirement increases by 10%, and pre-gestational type 2, your insulin requirement increases by 33%. You have various insulins, you have regular, I will not go into the details of insulin because it's just a 20-minute talk, but insulin alone has to be used. Maternal monitoring, you monitor by SMBG, you monitor by urine ketones, you monitor by blood pressure, urine protein, hemoglobin A1C in first trimester, fructose in later trimester. Now we have continuous glucose monitoring, which is a very wonderful tool. And if it's a pre-gestation, always monitor for a microvascular complication. In gestational diabetes, blood sugar should be monitored at least 4 times a day, fasting, and 3 postprandial sugars. And if the target is achieved, then you can monitor twice in a week. If the target is not achieved, you have to keep monitoring at least thrice or 4 times in a week. And most important, immediate postpartum. So insulin requirements disappear in GDM, and it changes to pre-pregnancy levels, and diabetes will disappear in 90% of the GDM case. And in this scenario, first trimester HbA1c will help you to decide what could happen. And continue monitoring 24 to 48 hours after delivery are indicated, and you have to monitor them for at least 3 years. Then it becomes a routine monitoring what has to be done. I'll just briskly go through 3 cases which would try to give better clarity what we have discussed now. So this is a 25-year-old female, preemie, 26 weeks pregnant, obese, no family history of diabetes or no PCOS. I'm sure universal screening, you have done a OGTT. Fasting is 100. So these are normal cutoff values, 92, 180, 153. This patient 1 hour is 198, 2 hours, all are borderline elevated, but this qualifies for the definition of GDM. Now, I cannot jump in and treat straight away for this patient. So what I do is I put this patient on diet, but I cannot wait for 2 weeks or 2 months for a diet. I tell them to do a glycemic profile for 3 days. So with this diet, glycemic profile for 3 days, your fasting is well within the range. And because your fasting should be less than 90 or 100, and your postprandial is 104, it is 1 or 2 numbers are high, but otherwise overall it is good. So I will not jump and treat this patient. I would say it is a GDM, but may not require treatment. You have another case scenario, 22-year-old female, second gravida, 24 weeks pregnant. You can see again fasting is somewhat similar to the previous picture. Now same thing, I do a diet for this patient, I do a glycemic profile, now it is totally changed. Your postprandial breakfast and postprandial dinner is high. So these things definitely has to be taken care of. So I put this patient on short-acting insulin, 4 units of Actrapid in the morning and night, and that will sort out the issue. So I'll give you another case 3, which is a 36-year-old female, previous history of GDM, fasting is 136 and postprandial is 201. You need not do a GTT for this patient. Already it is 201. Straight away you do a HbA1c which is 7.7, which suggests a pre-gestational diabetes which has been ignored. You treat them with routine insulin of Actrapid 4-4. This is what generally we do. And we tell them to monitor. Now what happens is first time as a patient answer, how long I have to monitor, how many pricks I have to do. So this is something continuous glucose monitoring is very, very useful for patients. So this is just a 1 rupee coin size which can be inserted, and this is you get a glycemic profile. So your post breakfast, post lunch and post dinner are slightly elevated. So now if I increase the dose of insulin, your pregrandial is going to go to hypoglycemia. So these are the scenarios where your analog insulins are very helpful. What we have done is we have just changed the Actrapid to a aspart analog insulin, and you can see the CGM which has become totally normal. So you have newer gadgets which really help us in treating our routine patients. I think I will stop with this. Yeah. I think just to conclude, the challenge one is what guideline to use. The answer would be you use any guidelines which you are familiar with, but constantly update the guidelines what you have been using. I follow 2-step GCT with OGTT because mostly they come to me after GCT. So it's easy for me to decide. The controversy here is early GDM, whether you have to be treated or not. I would say you go with a glycemic profile, simply blanketly we need not treat. The controversy 3 is challenge. When our first trimester, you see a patient with HbA1c of 9, whether to continue pregnancy or not is again a big challenge. And medical nutrition therapy is a challenge. And exercise, I would leave the controversy to the gynecologist. I would say you do exercise so they can decide. And drug therapy, whether you want to use insulin, metformin or oral anti-diabetic drugs. Insulin, you have the evidence, it's very safe, it could be used. And the biggest challenge is to apply your knowledge, your guidelines whenever you are sitting in the clinic. And applying your knowledge and treating the patient without controversy is the biggest challenge. Thank you.
Wonderful presentation. We enjoyed the talk, and there's so many practical tips to the practicing obstetricians. And as per Government of India guidelines, we are doing all the obstetricians. We are supposed to do only DIPSI screening, and then medical nutrition therapy, and then no role for metformin, and only insulin. And I want to know about this continuous glucose monitoring and that glucose pump, especially on the price wise.
Madam,
what's the affordability? And it will be very useful in type 1 diabetes, where in the first trimester there is more chance for hyperemesis and ketoacidosis, and we lost one patient last month in for these patients.
Use of one thing is very clear is in pregnancy glucose has to be monitored very frequently. I think there's no confusion. How exactly do you want to monitor? And even a single postprandial spike can have adverse outcome on your fetus. So basically, minimum requirement would be to do a fasting, and 3 postprandial would be a minimal requirement. So which means 4 pricks a day. If suppose you are going to do for 10 days, it becomes 40 pricks, and your glucometer strip costs roughly around 30 rupees. It is roughly around 1,500 rupees for the strip, and the glucometer comes to 2,500 rupees. But when you do a continuous glucose monitoring for 2 weeks, the cost is roughly around 5,000 rupees. It is just double of what it is. I think it is not too expensive, which is not affordable. It is slightly expensive, but the data you get from is very easy, and patient they find it very easy. They do not prick 4 times a day. It is very easy for the patient. But if again that becomes too expensive for them, now you have that is a patient sensor where they can see the blood glucose. There's a hospital sensor which is available, which costs just 2,200 rupees or so. So where you have to have a software to download the data. Instantly you cannot see, it's not a real time, but still if cost is a major factor, you can use it. When you are convinced patient has to be monitored for the glucose, I would say CGM is not very expensive.
I can add one thing. CGM especially is very helpful when you have nocturnal hypoglycemia or hypoglycemic unawareness. That's the only way you take it, and you protect the patient from severe seizures, hypoglycemic seizures. So if you do really, want to help the patient, especially want to intensify insulin treatment, CGM is a way to go. Yes, it's costly. Unfortunately, all technologies are costly.
I think especially when there's a discordance between the fetal growth and the blood glucose, CGM is definitely required, because we see many patients, when I referring to us, the fetus has grown, you see the diaphragmologist or you see another, bring them to blood. But whenever you monitor profile, it seems to be reasonably okay. Whenever there's a discordance, I'm sure CGM will definitely help to sort out the issue.
I think that is the question I was about to ask you also. So now and then we see patients with fasting hyperglycemia, but all the postprandial values are normal. And invariably, when you correlate, there seems to be a higher instance of fetal macrosomia in the group which is having a fasting
Fasting.
hyperglycemia. So to prevent macrosomia, will you like to start the patient on insulin, or you just follow the patient?
Again, this fasting hyperglycemia, it is with multiple factors. We have seen many of these patients nowadays because they sleep very late. They don't, we don't give 8 hours for measuring. They sleep by 12 o'clock, they are always in mobile, they are always in this thing. So fasting has so many factors to determine. But if we take only fasting hyperglycemia because of these things, generally if the blood sugar is between 90 or 100, we don't treat. But when it is slightly more than 100, especially when there's a fetal outcome is not very favorable, we would treat this patient. It depends on the fetal outcome. Simply blood sugar of 110, I may not treat. Blood sugar of fasting 110, other sugars are normal, no maternal complaint, no fetal, I may not treat. But if it has an impact on your fetal outcome, where no other factors are attributable, I would treat.
Recent days, there are a couple of patients who take polyhydramnios with fasting hyperglycemia. And the controversy was whether to treat or not.
In such patient, we can treat. But we should be sure they should not go to hypoglycemia with the diet. But when the 3 a.m. sugar is also high, along with the fasting blood sugar, I would treat for this patient.
So initially the woman was highly, she was on heavy insulin. Suddenly she went in from hypoglycemia, her totally stopped the insulin. And again she's coming. So what could be the reason for this?
Is it in pregnancy or any?
In pregnancy.
No, the pregnancy, one reason, patient, for example, patient 50 units of insulin, 50 units of insulin, with the same 50 they are ending with hypoglycemia, and again when you stop they are ending with hyperglycemia. The common error what we see is the insulin technique could be defective. Your insulin could have been expired insulin, or the insulin vial and the syringe could be mismatched. So basically it's a problem with either insulin or technique. So that would be the most common thing. Again, they inject in the same site. So absorption could be defective. There could be hypertrophy or hypertrophy. So these are the common things which happen. Yes. But I think the question is, in PCOS patient, we are continuing metformin up to 12 weeks. Why not we use metformin gestation diapers? Yeah. I think in PCOS, the data is very clear. Continuing metformin up to 3 months prevents your early abortions and your pregnancy outcome is better. We have data. So for PCOS, up to 12 weeks, it is very, very clear. As far as GDM is concerned, initially most of the guidelines with GDM was second trimester only. So we don't have data of whatever it is. And in GDM, you have a better insulin which is available than metformin. So whenever you have better insulin, they say you use it. It is very difficult to ethically do a trial comparing insulin and metformin in pregnancy. But I would say even in PCOS, we are not seeing much problem with your PCOS. Logically, your argument might be right. Yeah, I am using metformin for first 3 months, no tetrogenesis, no fetal malformation. Why not I use metformin in second trimester? Logically, you are right, but we don't have data. If medical legally some issue arises, the legal person may not be as intelligent as we are. So better be safe.
Ma'am, to answer your question, we do have data, not the big data. We do have data on metformin. We continue during second and third trimester. We do have data. It is very dicey. There are data which says it's safe, you can continue, but then we do have kids with metformin syndrome, it is called. Coming out, the fetus is having some developmental disformities and things. So we don't know whether that's secondary to uncontrolled diabetes or secondary to metformin. We do have, but those studies are very small. Like Dr. Kumar had said, we don't have a randomized control study. These are all observation studies. Thank you.
So more than 50 units or more than 100 units as such that they were not taking during pregnancy. So when to switch over to insulin pump, some are using because it is very cumbersome for the patient.
I think for want of time, I had a case on a patient on insulin pump, but I think insulin pump, it depends whenever there's a fluctuating blood sugar, nocturnal hypoglycemia, unawareness, brittle diabetes, definitely insulin pump is required. the unit of insulin is not the major deciding criteria for insulin pump. Type 1, brittle diabetes, nocturnal hypoglycemia unawareness, disproportionate fetal growth. Yes.
Prescriptions 2 units, 1 unit.
Madam, I think the minimum dose of insulin, what for syringe takes we can give. I think the dose which can be given is 1 or 2 units is a minimum which could be injected, but whether that will do some change for the patient, I'm not sure. One data was that they tried in patients with bad obstetric history. One group was given 4 units of insulin without GDM or without diabetes, and one group was treated with a conventional treatment. They found those patients who received low dose of insulin, your fetal outcome was better. And again, as Dr. Anand, these are small studies. This may not warrant you to use small dose of insulin for patients.
Thank you. I think for want of time, we need to move on to the next topic. But I would like Dr. Padma to felicitate Dr. Kumaravel.